Case presentation. My name is Daniel Rosas and my co-authors are Abhishek Panya and Dr. Jane O'Rourke. We present a case of acute lung injury secondary to transcatheter arterial chemoembolization, also known as a TACE procedure. For introduction, shortness of breath commonly is from a pulmonary or cardiac origin, and a detailed history and physical exam help differentiating both. On a different note, the TACE procedure is used as a local regional treatment for hepatocellular carcinoma with promising results. This procedure consists of a catheter-guided doxorubicin local injection in the tumor itself on the liver. Its main adverse effects is local inflammation of the liver, but there is also emerging data showing that this therapy can lead to different presentation of acute lung injury. These complications have included pulmonary oil embolism, interstitial pneumonitis, chemical pneumonitis, ARDS, among many others. The mechanism of action for this injury is not quite understood, but it's expected to be secondary to migration of doxorubicin to the lung vasculature, causing inflammation and alveolar capillary membrane injury. The case presented is a 65-year-old female with past medical history of COPD, hepatitis C cirrhosis, and stage 2A HCC that presented with progressive worsening dyspnea, a now 9-pound weight gain, and a non-productive cough that started 10 days after undergoing TACE. The patient underwent TACE with doxorubicin plus micron beads and started experiencing dyspnea unresponsive to her daily inhalers. Upon evaluation in the ED, she had tachypnea and bilateral rales without wheezing. For labs, BVG was unremarkable, BNP was 541, having in mind that she had a BMI of 32, a Procol and RVP were negative. The chest x-ray revealed no consolidation, and the TTE showed preserved ejection fraction with diastolic function not assessed due to the patient's body habitus. She was treated with Lasix for the first 2 days without significant improvement in symptoms. Prednisone was then started on day 2 of hospitalization with marked improvement and completed a 5-day course of steroids with resolution of symptoms. For the discussion of this case, given the temporal relationship in patients' respiratory symptoms after undergoing TACE, it is likely that the patient experiences TACE-induced lung injury. Although the patient had underlying COPD, the absence of wheezing, absence of productive cough, and the unremarkable chest x-ray and BVGs argue against a COPD exacerbation. She did have a 1+ lower extremity edema on presentation with mild elevation in BNP. However, the TTE showed preserved ejection fraction and the symptoms did not improve with diuretic use. The mainstay of therapy for TACE-induced acute lung injury after reviewing the literature was exclusion of infectious etiology, supportive care with supplemental oxygen, and systemic steroids. Although the steroids are used widely to treat what is thought to be drug-induced pneumonitis, this treatment has not been evaluated in controlled clinical trials. Our conclusion for this case is that this case is unique given the uncommon diagnosis of TACE-induced lung injury.